Hi, everyone, and welcome to today's webinar, Optimizing IBD Management with Fecal Calprotectin from Diagnosis to Monitoring. My name is Bethany Bell, and I am the Vice President of Global Business Development for ALPCO, and I will be your moderator today. This webinar will focus on the treat-to-target approach to IBD, highlighting the critical role of non-invasive monitoring methods, particularly fecal calprotectin monitoring, in guiding treatment adjustments and achieving therapeutic goals. I'm excited to be hosting today's session and pleased to introduce our accomplished speaker, Dr. Benjamin Click. Dr. Click is Assistant Professor of Medicine at the University of Colorado Crohn's and Colitis Center and has served as Principal Investigator on multiple clinical trials in IBD. He is board certified in internal medicine and gastroenterology. Before I hand the mic over to Dr. Click, I have a few housekeeping items to cover. First, today's presentation is being recorded. You will receive an email within a few days with a link to access the recording, which you can share with colleagues who are unable to attend. Next, we'd love to hear from you during today's presentation. If you have questions, please feel free to send them through the chat box. We'll be answering the questions at the end of the webinar. If we don't get to your question during today's session, we'll be sure to follow up shortly after. So without further ado, I'd like to kick things off by welcoming our speaker, Dr. Benjamin Click.
Well, thank you, Bethany, and to the entire ALPCO team. It's really my honor to be discussing optimizing IBD management with fecal calprotectin today. These are my disclosures, and what we'll aim to do over the next, say, 40 minutes. So what I was mentioning in the aforementioned slides, I'm sorry that the audio visual cut out. Hopefully you can hear me, and please interject if I lose connection again. What we were reviewing is this idea of mucosal healing as being the gold standard for our outcomes in managing inflammatory bowel disease. And this was really borne out in some of the post hoc analyses from the CALM trial, which we'll review, wherein they clearly differentiated the risk of disease progression in individuals who achieved mucosal healing as measured by endoscopic remission and deep remission, which was a combination of clinical and endoscopic remission. And so you can see a clear difference in that disease progression risk by individuals who achieved that outcome. So that's where mucosal healing has really become our gold standard for in terms of interpreting our success in managing inflammatory bowel disease. And the same is true in ulcerative colitis as well as Crohn's disease. But assessing mucosal healing has downsides. There are issues with colonoscopies. It's costly, it's invasive and risky. As you can see on the picture on the left here, an endoscopist who holds the scope in the wrong hand and doesn't have any buttons is probably a higher risk procedure than not. Procedures are time consuming. Patients have to take off work, usually for the prep and travel, in addition to the procedure itself and recovery therein. There's limited access to colonoscopies, and timely access becomes a consideration when we're assessing disease activity. And then, of course, patient preference is critical here. So when talking to patients, there have been studies looking at preference for disease activity assessments, and colonoscopies fall somewhere in the middle. And so patients may not prefer to have that as their gold standard in terms of a target of therapy. I previously mentioned the CALM study, and the CALM study is really one of these pivotal clinical trials that informs our management paradigms in inflammatory bowel disease. It was published a few years ago now, but it was a randomized trial asking the question, can we use biomarkers as a potential surrogate and reflection of mucosal healing and disease activity, and does incorporating routine biomarker assessments into our clinical practice improve our clinical outcomes? So CALM was a randomization of individuals with Crohn's disease, generally early in their disease course, so within the first few years after diagnosis, to either a, quote, tight control group, which included treatment optimization based on biomarkers, which in the CALM study were CRP and fecal calprotectin, as well as clinical symptoms, compared to a standard of care clinical management arm, which only looked at clinical symptoms as a marker of disease activity and an indication for treatment adjustment. Individuals were monitored every 12 weeks, and the primary outcome at 1 year was mucosal healing, which included an endoscopic score less than 4 and no deep ulcers on colonoscopy. And what the CALM study critically showed us is that incorporating biomarkers into our routine clinical assessments does improve mucosal healing rates at 1 year, and likely, as I told you before, likely changes that long-term course of an individual with Crohn's disease. When they did a deep dive on what the indications were for treatment adjustments in the treat to target arm, they found that fecal calprotectin was actually the most frequent indication for treatment adjustment in that arm. So the CALM study helped inform this concept of what we call treat to target, meaning that when we start therapy for an individual with inflammatory bowel disease, we should be selecting our outcomes that we want to measure, follow, and hopefully achieve. Generally, it's thought now that mucosal healing, like I mentioned before, is the holy grail of clinical outcomes. But we have to understand that this is a progression and we need to incorporate other surrogates, and this is where biomarkers come in and play a pivotal role. And so this was a critical publication, the STRIDE-2 guidelines, which were published just a few years ago, that really lay out some of the short-term targets that we should be thinking about and discussing with patients, intermediate and then long-term targets, i.e. mucosal healing, as well as the avoidance of disease progression. And so you can see early on some of our short-term targets include a symptomatic response to therapy, as well as that biomarker remission and normalization, and then progressing towards, in the long term, that status of mucosal healing. So if you haven't read the STRIDE-2 guidelines or are familiar with this, I'd highly recommend this to our audience today as a potential reflection of our current standard of care in managing inflammatory bowel disease. But now let's dive into the meat of our discussion today about how do we actually do this and what are the tools that we can implement in our clinical practice to achieve biomarker monitoring and hopefully mucosal healing. And I'm going to focus on fecal calprotectin today. So what is fecal calprotectin first and foremost? Calprotectin is a calcium and zinc binding protein. It's actually the predominant protein in the cytosol of neutrophils. Actually, it makes up about 60% of cytosolic protein in neutrophil cells. Gastrointestinal inflammation inherently involves neutrophil migration, activation, and then they release their cytosolic proteins into the gastrointestinal lumen. That fecal calprotectin, it remains stable in the stool for up to 7 days at room temperature. And now there are a number of different assays that can quantify the amount of calprotectin in the stool samples using several different mechanisms, including ELISA and lateral flow immunoassays. And most commercial labs now have these routinely available. Fecal calprotectin is a very accurate reflection of gastrointestinal inflammation. This is data from Crohn's disease on the left and ulcerative colitis on the right, demonstrating the correlation of fecal calprotectin levels on the x-axis compared to disease activity endoscopically on the y-axis. And you can see that there are clear correlations for both Crohn's disease and ulcerative colitis. So it's a nice reflection of what's happening inside the gastrointestinal tract. And what this means is we can also use fecal calprotectin not only in the monitoring of our inflammatory bowel disease patients, but we can actually use it to help triage our initial clinical evaluations and diagnosis and diagnostic strategies. So the data on the left shows fecal calprotectin levels in individuals with either irritable bowel syndrome, other colitis, or inflammatory bowel disease. And you can see a clear increase in difference between those with IBD and IBS. And so fecal calprotectin can be used to triage between 0.01 and 0.07. What this means is if your fecal calprotectin is normal, there's between a 93 and 99% likelihood that that individual does not have inflammatory bowel disease. So it's a very good negative predictive test when triaging these patients who are trying to distinguish, do they have IBS, not quite fitting the Rome criteria, do they have a red flag sign or symptom? It can be very helpful for determining who needs additional workup versus who can be managed more conservatively. Calprotectin monitoring in inflammatory bowel disease after making that diagnosis can actually help prognosticate outcomes as well. This is data from Charlie Lees's group in Edinburgh that has an extensive registry looking at fecal calprotectin and clinical outcomes. And this was data in Crohn's disease where they dichotomized individuals by what happened with their fecal calprotectin over the first year of their clinical course. And they compared people who either normalized their fecal calprotectin to individuals who did not normalize their fecal calprotectin within the first year of treatment. And what they found is that people who normalized their fecal calprotectin actually had lower rates of disease progression. And that was defined by a change in disease behavior, development of new perianal disease, hospitalization or surgery, as compared to those who did not normalize their fecal calpro. So that early first year trajectory of fecal calprotectin may be able to prognosticate the long-term outcomes as well. When they looked into what those quantities were telling us within that first year, there's a really interesting story. So I'm going to draw your attention to actually the first 2 months after initiating treatment. And you can see that individuals with the red line were those who did not experience disease progression, whereas the blue line is those who went on to develop or experience disease progression. And you can see there's a clear difference even within the first 2 months of the fecal calprotectin response. And so perhaps we can get an idea and identify these individuals who are at high likelihood of responding versus those who are high likelihood of not responding and experiencing disease progression, even within the first 2 months, by monitoring, measuring, and comparing fecal calprotectin trajectories. Well, that was Crohn's disease. Ulcerative colitis has a similar story. This is data from a randomized trial looking at dose escalation or addition of mesalamine to individuals with ulcerative colitis with active disease. And they found essentially that individuals who normalized their fecal calprotectin had significantly lower likelihood of subsequent clinical relapse as compared to individuals who did not normalize their fecal calprotectin. So again, harping on the idea that fecal calprotectin can be a very helpful biomarker in strategizing and triaging and prognosticating really our inflammatory bowel disease courses. I'm going to paint a different picture now and show another potential role of fecal calprotectin in that it can actually predict clinical relapse in Crohn's disease and ulcerative colitis. This is data from the STORY trial. The STORY trial was a prospective trial of infliximab discontinuation in steroid-free remission in individuals with Crohn's disease. So they took away the infliximab and then they monitored them very closely. And part of that monitoring was obtaining fecal calprotectins every 2 months. And what they found is that after withdrawal of infliximab and routine obtainment and measurement of fecal calprotectin, one can actually see the fecal calprotectin rise as many as 4 months before the subsequent clinical relapse and disease activity flare came to light. So we can actually detect early and potentially intervene early by monitoring fecal calprotectin based on this data. And similar data holds true in ulcerative colitis, that fecal calprotectin monitoring and elevations in fecal calprotectin can predict subsequent clinical relapse. Data both on the left and a meta-analysis on the right looking at this association and predictive ability. Now, another subgroup that I'm going to draw attention to, and we'll come back to this a little bit later in the talk, is Crohn's disease individuals who undergo a surgical intervention. Fecal calprotectin is a very ripe area of opportunity and interest for monitoring the postoperative Crohn's disease population. What I'm showing here in this slide is actually data from the POKER trial. The POKER trial was a randomized trial of when to look with colonoscopy in the postoperative setting. Individuals were randomized to either look at 6 months or 18 months postoperatively. And as part of the clinical trial, they obtained fecal calprotectin measurements at various time points. And what this study and this data shows is that fecal calprotectin levels actually associate quite nicely with concurrent development or detection of endoscopic Crohn's disease recurrence in the neoterminal ileum. The authors went on to identify some optimal test characteristics of fecal calprotectin and suggested that a cutoff of about 135 micrograms per gram in the postoperative setting had a sensitivity of about 91% and specificity of 62% for associating with endoscopic Crohn's disease. And interesting, and this may evolve in terms of our clinical practice and implementation, fecal calprotectin measurements early on could predict subsequent detection of endoscopic recurrence. So again, similar to that idea of early detection of subclinical disease activity, fecal calprotectin may do the same thing in a postoperative setting, and we'll return to this concept in this subgroup in a short period. There are some key differences to know between Crohn's disease and ulcerative colitis in regards to fecal calprotectin monitoring and really this treat to target concept. Really, there's less data in ulcerative colitis. We actually don't have much data in ulcerative colitis that, as compared to Crohn's disease, early effective therapy, meaning shortly after diagnosis, putting people on an advanced therapy is better necessarily than a step-up strategy. So a little bit of a difference in ulcerative colitis versus Crohn's disease. There's actually some retrospective and post-hoc data that disease duration may not impact an individual's likelihood of response in ulcerative colitis as compared to Crohn's disease, which I showed you earlier. And importantly, we don't have a similar related randomized controlled trial of a biomarker-based monitoring and treatment adjustment strategy a la the CALM study in ulcerative colitis like we do in Crohn's disease. Importantly, and perhaps this audience knows this very well, that symptoms are much more reliable in ulcerative colitis as compared to Crohn's disease. And what this means for implementation of biomarker monitoring and subsequent clinical adjustments in therapy or decision making is that it changes the pretest probability. So if we look at the table down below, we see that comparing the likelihood of significant clinically meaningful endoscopic disease activity in individuals who are asymptomatic, there's significantly higher rates of disease activity endoscopically in Crohn's disease as compared to ulcerative colitis. So Crohn's disease needs a little bit more trust but verify as compared to ulcerative colitis. Now I'm going to change gears and we're going to use a patient scenario to help illuminate some recent evolutions and guideline statements regarding biomarkers. So we're going to be talking about John. John is a 34-year-old male who presents with abdominal pain, diarrhea, some blood in his bowel movement, and overall there's a concern for underlying inflammatory bowel disease. So some key questions when thinking about the role and implementation of biomarkers, and in particular fecal calprotectin, come to mind immediately. When do I check the first fecal calprotectin? How often and when do I follow this fecal calprotectin? Let's say that we know John has active inflammatory bowel disease. Do I repeat it once a month, like the data I showed you before, every 2 months, every 6 months? What if John goes into remission with a treatment? How often do I follow it at that point in time? Am I allowed to adjust treatments simply based on the fecal calprotectin, or do I need some confirmation? And what level of fecal calprotectin allows more clinical certainty in making that decision-making progress? I'm highlighting here some recent guideline publications over the last year in both Crohn's disease and ulcerative colitis that if you haven't read yet, I'd highly suggest reading. These are excellent clinical practice guidelines that do a very thorough job in evaluating the role of biomarkers and really go through a very detailed examination of the clinical reasoning for the implementation and recommendations related to biomarkers in the management of inflammatory bowel disease. We're going to walk through what these guidelines say in the next few slides. There's a very high-level summary of these guidelines. These guidelines are many, many pages long, and I'm doing them a little bit of an injustice by summarizing in 2 slides, but we're going to do our best to give them due diligence here. So what the biomarker guidelines in Crohn's disease and ulcerative colitis state is that for individuals in remission, they recommend utilizing a combination of biomarkers with symptoms over a strategy that only assesses symptoms alone. In individuals who are in remission, we can follow these biomarkers every 6 to 12 months to confirm and perform a disease activity assessment in combination with symptoms. If we check that biomarker, and in particular fecal calprotectin, and the level is less than 150 micrograms per gram, we can safely presume, based on the available data, that there is no clinically significant underlying active inflammation, and thereby we can actually obviate the need for an endoscopic or radiographic examination in these individuals. Importantly, despite this recommendation, individuals with Crohn's disease should really be undergoing periodic endoscopic confirmation of that disease remission, and that goes back to that uncertainty related to Crohn's disease clinical symptoms and really anchoring our assessments of the biomarker predictive ability in this scenario based on their endoscopic remission status. So about every 3 years for Crohn's disease, we should be re-anchoring our biomarkers and restating whether or not they're in endoscopic remission, and then implementing this biomarker monitoring strategy. However, if an individual is in clinical remission, meaning no active symptoms, yet their fecal calprotectin returns greater than 150 micrograms per gram, that is an indication to then follow that test up with either an endoscopic or radiographic assessment, depending on an individual's Crohn's disease location, for example, and determining the disease activity based on that and treatment adjustments thereafter. The one exception to that is if an individual is in sustained remission, meaning for years they've been in clinical remission, previous biomarker assessments have all been normal, perhaps you've done an endoscopy relatively recently, and you get all of a sudden a fecal calprotectin elevation, you can also consider simply repeating that biomarker in about 3 to 6 months. I tend to err on the shorter side, again, going back to that data showing the clear elevation in fecal calprotectin can be predictive of a clinical flare. So I tend to repeat that on the shorter time frame mentioned there at 3 months. But I'm also talking to these patients about just proceeding directly to endoscopy or imaging. The other exception is that if an individual has recent disease activity, they were not in remission, they had clinically active disease, they had elevated biomarkers, and you adjusted treatment, and now they just entered clinical remission, so they're fresh into clinical remission, yet they still have its elevated fecal calprotectin level. One can presume that that is reflective of active inflammation, and you can go ahead and adjust the treatment, obviating the need for an endoscopic confirmation, especially if you had endoscopic confirmation of disease activity when you started, initiated, or changed that therapy fairly recently. Now we're going to switch gears from remission into symptomatically active inflammatory bowel disease, both Crohn's disease and ulcerative colitis. And what the AGA guidelines recommend for both disease states is that they recommend using biomarkers and symptoms over symptoms alone, very similar to those in remission. For active disease, they recommend a strategy implementing biomarker monitoring about every 2 to 4 months. Individuals with mild symptoms, and we'll talk a little bit more about what mild symptoms mean, should actually proceed directly to endoscopic and radiographic assessment. And this is because if you have an individual with mild symptoms and a low fecal calprotectin, it doesn't necessarily explain why they have mild symptoms, and so confirmation with the gold standard endoscopic or radiographic assessment is warranted. And if an individual has elevated fecal calprotectin, then that's a indication that the symptomatology doesn't necessarily match with the degree of inflammation, and corroborating and evaluating that discrepancy is warranted. So they recommend that assessing biomarkers, and this is my clinical practice in Clinical Pearl, is that even if I'm proceeding directly to endoscopy or radiographic assessment in individuals with mild symptoms, I'm still obtaining a biomarker. And the reason for that is I'm trying to benchmark what that number means to the gold standard disease activity assessment, so that moving forward, I can then implement a more informed monitoring strategy for that individual. For individuals who still have mild symptoms despite a recent treatment initiation or change, and they have an elevated fecal calprotectin, again, that can drive treatment adjustment without necessarily confirming that endoscopically or radiographically. Compared to mild symptoms, those individuals with Crohn's disease and ulcerative colitis who have moderate to severe symptoms and elevated fecal calprotectin monitoring, elevated fecal calprotectin levels greater than 150, that can be confidently associated with a likelihood of underlying endoscopic disease and active inflammation, and we don't necessarily need endoscopy or imaging to confirm that, and we can therefore make treatment adjustments. The one consideration and asterisk that they put in the guideline is that if you're considering, or your next move with an individual is changing a therapy, something like a high-risk treatment adjustment, changing therapy, stopping a therapy, moving on to a different mechanism, that may be a time to discuss pursuing an endoscopy or radiographic assessment just to confirm, because that is a bigger deal to change therapy than, say, increasing the dose of infliximab or adalimumab compared to changing therapy. So let's walk through a little bit of a paradigm in terms of actual implementation of a biomarker monitoring strategy. First is we're going to make a diagnosis, or we're going to say somebody has active disease confirmed by colonoscopy. We assess our baseline fecal calprotectin, and this is where I really use that term benchmarking. So even though I've made the diagnosis or I know what their gold standard disease activity is, I'm still obtaining my fecal calprotectin because this is what we're going to follow moving forward. And I really want to see how these line up so that I have a very educated association and correlation within that individual. So we make the diagnosis, we check our biomarker, it confirms and correlates very well to what's happening on the inside. We start a therapy, in this case, Agent X. And then 2 months later, I'm bringing that individual back for my first symptom assessment combined with biomarker monitoring. Remember, with active clinical disease, every 2 to 4 months with fecal calprotectin, I tend to err on the side of earlier is a little bit more informative. Going back to that data, that even that first 2-month window of the fecal calprotectin trajectory can be prognostic, can predict an individual's long-term disease course. So 2 to 3 months later, I'm bringing that individual back. Let's say they're responding, they're in clinical remission, and the fecal calprotectin is less than 150. I then shift into my gold standard mucosal healing assessment, which is obtaining a colonoscopy 6 months after the start of that therapy. And again, I re-benchmark my fecal calprotectin at that examination to follow and make sure I have a good correlation with that test. Then moving forward, 6 months later, I bring that individual back to clinic for another symptom assessment, again, combining the symptom assessment with another fecal calprotectin, demonstrating clear fecal calprotectin remission. And thereafter, if this individual remains in stable clinical and biochemical remission, I repeat that assessment about every 6 to 12 months. Let's change the scenario a little bit and see how this implements or affects our biomarker monitoring strategy and timeline. So same idea, make the diagnosis, check the fecal calprotectin, start a therapy, and bring them back 2 to 3 months later. But this time, maybe the individual is having a partial clinical response, but their fecal calprotectin remains significantly elevated, greater than 150. Well, as previously stated, that is indicative of active inflammation endoscopically, and I don't necessarily have to confirm that endoscopically. I can go ahead and make a treatment adjustment. So for example, in this case, maybe I deem this a primary non-response and change to a different agent, in which case I basically start the clock over again. 2 to 3 months after that change to the second agent, I'm bringing that individual patient back for a symptom assessment, fecal calprotectin monitoring. In this case, it's still slightly elevated above 150. So maybe I increase the dose of the second agent, maybe I decrease the frequency or some sort of modification or optimization of therapy. And then again, at month 8, which is 6 months after the second agent in this scenario, that's when I'm performing my mucosal healing assessment. So basically restarting that clock every time there's a change in therapy and monitoring that very closely with a combination of symptoms and biomarkers. So let's say in this scenario, John enters clinical, endoscopic, and biochemical remission. We all high five and cheer that we've hit our gold standard monitoring outcome there. But 3 months later, you get a report from John that he thinks he's having a flare. And this is what the AGA guidelines recommend in terms of monitoring active disease. First, we need to triage by that symptom burden. Individuals with mild symptoms defined by 3 to 5 bowel movements per day, mild abdominal pain, differ in the diagnostic evaluation. So let's say John reports he's having just a few more bowel movements than normal, maybe a little bit of cramping. Well, in that case, I'm proceeding directly to colonoscopy to confirm that. Again, remember, no matter what the calprotectin or biomarker says, it's still recommended to differentiate that disease activity endoscopically. I still obtain a biomarker, and again, I put here that it's really to benchmark, but I'm not basing my clinical management decisions on that calprotectin result. And of course, with any change in symptoms in IBD, I'm obtaining a C. diff test to make sure we don't have concurrent infection, and I'm really treating based on the findings of the colonoscopy in particular. However, if John reports that he's having more moderate to severe symptoms, again, I'm obtaining a C. diff test, but this is where biomarkers can help differentiate the treatment algorithms and next steps. So if John has an elevated fecal calprotectin greater than 150, I don't necessarily need a colonoscopy. I'm going to adjust my treatment in that case, with the caveat that if the next treatment adjustment is a change in therapy, we could discuss a colonoscopy just to make sure and that everybody's comfortable with such a change. However, if the fecal calprotectin is less than 150, that's a situation where we want to figure out what exactly is going on, what's driving those symptoms. So we go to our gold standard colonoscopy and/or imaging and treat based on those findings. We're going to circle back to postoperative Crohn's disease next and really go over what the biomarker guidelines comment about postoperative Crohn's disease. So for those of you who may not be familiar with the current state of postoperative Crohn's disease guidelines, it's currently recommended based on the 2017 AGA guidelines that we differentiate individuals into either low risk or high risk for postoperative recurrence of the Crohn's disease. And there are some risk factors here that help us differentiate this. These are largely clinical risk factors. People who are deemed to be higher risk are generally younger at the time of surgery, active smoking, have penetrating intra-abdominal or perianal Crohn's disease, had a long segment resection, and of course, individuals who've had multiple prior surgeries before are higher risk for that happening again. And so what the AGA shined a light on in this episode of the biomarker guidelines is that we may be able to think about fecal calprotectin as a test that could potentially obviate the need for the currently recommended colonoscopy monitoring in postoperative Crohn's disease. So currently it's recommended that everybody undergo an endoscopic evaluation within 12 months of their surgery. Generally, I do it at about 6 months based on the data from the POKER trial showing looking earlier can change the clinical outcomes in the postoperative setting. However, the new guidelines say that for individuals at certain risk levels and who are undergoing certain prophylactic strategies by implementing or utilizing our advanced therapies postoperatively, may be able to undergo simple biomarker assessment within that first year. And this table really walks us through what those combinations of and what the recommendations are. So for individuals who are low risk for recurrence, who are either on or not on medical prophylaxis postoperatively, you can actually consider implementing either a fecal calprotectin strategy, measuring the fecal calprotectin within 12 months post-op, and if it's less than 50, you can actually obviate the need for a colonoscopy within that first year. For an individual at low risk on prophylaxis, actually you can even bump that cutoff up a little bit from less than 50 and even consider a higher threshold to actually act of 150. And that's largely based on that data I showed you before of the POKER clinical trial. Now, shifting gears to probably the majority of our patients, especially if you're in a referral-based practice, individuals who are high risk for recurrence. If you're on prophylaxis, again, you can actually follow a calprotectin-based monitoring algorithm, and if it's normal, potentially obviate the need for a colonoscopy. The only population where they still recommend and don't give the option for fecal calprotectin monitoring is this high-risk population that is not on medical prophylaxis. I want to spend the next couple of minutes really talking about the potential pitfalls or things to be aware of with fecal calprotectin and inflammatory bowel disease. So number one, you have to know what the availability of fecal calprotectin is. It still requires a commercial lab. That lab has to be able to perform the fecal calprotectin assay. There's issues with sample collection, storage. It's generally stable, but it's not stable forever. And then a patient has to submit that sample, and they have to travel to do that. And particularly for patients who don't have a convenient laboratory location, that becomes a big issue and impacts adherence to a fecal calprotectin monitoring strategy. Coverage for fecal calprotectin varies. It's not universal. We find plans that cover it widely. We find some plans that don't cover it all. There are also plans out there that actually have frequency limits. So some plans in my area, for example, will cover 1 fecal calprotectin per year, but no more, and any more go directly to out-of-pocket costs for the patients. And patients may not like performing stool tests. So we know that patient acceptance is variable, and it really depends on an individual patient. We'll talk about some strategies about how we improve patient acceptance, but it's not their idea of a great time to be poking their poop usually. Test characteristics of fecal calprotectin are critically important. So first, there's intra-individual variability of calprotectin assays. So there have been studies that have looked at the same stool sample in the same individual and shown very high rates of variation in the actual number that comes out of that assay. Generally, that comes with higher ends of the spectrum, so higher fecal calprotectin levels have more wiggle room and variability in their reporting. But nonetheless, it's important to understand that even within a stool sample or an individual, you can see variations in fecal calprotectin. It's been shown that the first stool test of the day is the most reliable and accurate. So that's an important clinical pearl when you talk to patients about when and how to submit this test. There's also inter-assay variability. So from lab to lab, assay to assay, you can get different numbers. And it's been shown that as high as 5-fold differences across different laboratory commercial assays, and again, often at the higher end of the spectrum, but be aware of what your local labs potentially vary in between. There are false positives with fecal calprotectin. So again, it's just a measurement of neutrophil activation and release of calprotectin into the GI lumen. So anything that does that can give you an elevated fecal calprotectin. Infections, non-steroidals, inflammatory polyps, malignancy, perianal disease, or non-IBD enterocolopathies, and ulcers can all give you an elevated fecal calprotectin. So it's helpful, but again, still has to be placed into a little bit of clinical context. And then even with confirmed inflammatory bowel disease, there can be some false negatives. So we know that proximal small bowel Crohn's disease can be a little bit less reliable in terms of its reflection of luminal disease activity. And similarly, if the ulcerative colitis is more segmental, that does correlate less well than, say, with pan-ulcerative colitis. I'm going to spend the final slide on pragmatic tips for implementation with fecal calprotectin and how do we successfully build a monitoring strategy and platform for successful integration into our clinical practice. And I've broken it down into these 4 concepts. So first, the fecal calprotectin landscape. It's important for every clinician to be aware of what their lab offers in terms of, number one, do they have fecal calprotectin? What assay do they actually use, and what that local inter-assay variability looks like. I always try to encourage patients to use the same lab longitudinally, and that allows me to reduce that variability. Now, if patients bounce around from a commercial lab to commercial lab, it makes it a little bit more challenging to fully interpret those results. And then being aware of, your general big players or payers in the area, what they cover, do they have potential limitations, and also bringing that up to patients so that they're aware of that possibility and they can feed that information back to you to help integrate into your fecal calprotectin or biomarker monitoring. Patient education, I can't emphasize this enough, is key to successful implementation of fecal calprotectin. And it's probably the most important thing that you can do. So sitting down, taking a few minutes and explaining this concept of treat to target monitoring with fecal calprotectin. Why is it important? It's important to help us achieve mucosal healing. It's helpful to monitor longitudinally to reduce the risk that they have a flare, for example. And we also go through and educate patients about, okay, this is when I want to repeat it. This is how often I want to repeat it. And these are some of the interpretation considerations. And I think that goes a long way with patients' anxiety about test results as they get released to the portal, especially very rapidly, making sure that they understand a level of 57, which comes back as elevated, is not the end of the world, and kind of spending a minute or two walking through their patient preferences in terms of what they would want to do in certain situations based on biomarker outcomes. Benchmarking fecal calprotectin is really, really important. So generally, I tell my patients for every colonoscopy that we're doing, I want a fecal calprotectin 1 week prior. That allows me to get the results back to understand when I'm doing the colonoscopy what that number means, but it also avoids some of the potential false positives if they submit a sample after the colonoscopy, biopsies, prep, et cetera, that may drive a falsely elevated number. And then I repeat that benchmark periodically. I try to remove as many fecal calprotectin barriers as possible. We keep stool collection kits in our clinic, and every time I'm ordering a fecal calprotectin or I want one in the near future, I will give a patient that stool collection kit. That saves them a trip to their lab. Again, especially if they have to drive a long distance, it's one more thing, one more barrier to a successful implementation that we being utilized. This is data from Europe, where they have an approved assay and device which allows patients to measure fecal calprotectin at home, take a picture of the results, which then get uploaded into the electronic medical record for clinical interpretations. It is not currently approved in the United States. It's currently with the Food and Drug Administration, but nonetheless, it may be coming to a clinic near you in the future. So in conclusion, for fecal calprotectin, treat to target strategy using a combination of symptoms and biomarkers with mucosal healing assessments with endoscopy is the current standard of care. Fecal calprotectin is a reliable biomarker to detect clinically or subclinically active inflammatory bowel disease. Guidelines now recommend implementing biomarker-based strategies for assessing active disease, generally every 2 to 4 months, or monitoring remission, generally every 6 to 12 months. And really making clinical decisions can utilize biomarkers combined with symptoms alone, potentially obviating endoscopic assessment in certain situations. There's some subpopulations where fecal calprotectin may provide a critical role here, particularly with postoperative Crohn's disease monitoring. And finally, spending some time with patients, educating them about fecal calprotectin, understanding some of their concerns, limitations, and barriers, and trying to minimize those are really key strategies to actively and successfully implementing and integrating fecal calprotectin into your clinical practice. So with that, thank you. I apologize again for the audio-visual issue, and hopefully it'll be smooth sailing from here. And again, thank you to ALPCO for the opportunity to present today.
Thank you, Dr. Click, for a great presentation. So just to remind everybody that's listening, if you have any questions, there is a chat box at the bottom that you can enter them into. I do have a few to answer, so hopefully we can get to everybody. So the first question that came in is around that kind of intra-individual variability that you discussed. You suggested that you could have up to 114% variability. So the question is, does that variability necessitate the need to get multiple samples from a single patient over a defined period of time before a true baseline can be achieved for them?
It's a great question. I think more data is always helpful, but again, the variability, especially that high range of variability, is more often seen at the high end of the fecal calprotectin spectrum. And what that means is you may get a level of 3,000 back with one assay, maybe it's 5,000 with a different assay or different stool test, but it's generally above your clinical threshold action points. So it's very rare that I get one that really differentiates from completely normal to something above the threshold of a clinical decision time. So I think more data is always better, and that's why I emphasize the role of benchmarking to our gold standards with colonoscopy, cross-sectional imaging in certain situations to really set that benchmark and understand that individual variability potential. So maybe somebody's in complete clinical remission, no ulcers, no active disease, yet their fecal calprotectin is 90, in which case I understand that their gold standard, their baseline is 90. So if I get a level back in 6 months and it's 120, I'm not overreacting to that, and really setting that benchmark allowed me to make that interpretation.
Okay, thank you. So the next question here is a little bit around the patient education and compliance with calprotectin testing. Have you experienced having patients referred to you from their primary care physician that have already undergone calprotectin testing? Or do you feel that it really requires a GI physician who's got the expertise before that calprotectin test is asked for or requested?
No, I think this is a great question and really an ongoing conversation currently. I think there's a big push to educate primary care providers across the nation and globe in implementing fecal calprotectin triage for these types of patients. What we see in the US, it's not a big problem, but especially in Europe and more societal healthcare institutions, we see there can be significant delay in getting patients to specialists. And so if a primary care provider is comfortable placing that order and really saying, is this normal or abnormal? If it's normal, then that saves a referral and they can potentially initiate more conservative therapy. And of course, if it's abnormal, I think that should expedite the referral to a gastroenterologist for additional diagnostic testing. And maybe the primary care provider goes ahead and orders the colonoscopy or imaging based on their degree of concern. So I think the more that we can move such a diagnostic strategy and triaging earlier into the patient care journey, I think that allows us to make a diagnosis earlier, implement early effective therapy, like I mentioned, and change the potential natural history. There's good data out there that we have significant diagnostic delays in inflammatory bowel disease, particularly in women, more so than men. So the earlier we can get that diagnosed and acted upon, the better.
Okay, thank you. So the next question is, you highlighted false positives and false negatives for calprotectin testing. As a manufacturer of tests, what are acceptable false positive and false negative rates from a physician standpoint?
Yeah, that's a really good question. Obviously, the more accurate you can make the test, is the ideal state. What the acceptable rate is, it varies, and it varies on the clinical situation. So I mentioned, that the guidelines do a really thorough, in-depth evaluation of what are acceptable ranges of false positives, false negatives, based on the potential downstream consequences of missed disease activity, for example. And so I think it really depends on that situation. So you saw in the postoperative Crohn's disease example that the cutoff is less than 50. So if it's less than 50, that obviates the needs for a colonoscopy. But if you look at the luminal Crohn's disease and ulcerative colitis guidelines, they use 150. So that's because of that change in the pretest probability and the potential downstream consequences of missed disease activity. So it's hard to give you like, okay, 5% for everybody in every test. It really depends on the situation because the consequences differ based on the pretest probability and potential implications.
Okay, so I'm going to give you one more question and then we'll wrap up just so that we don't run out of time in the middle of your answer here. So if a new biomarker could improve IBD management, what specific data or insights do you hope that it would provide?
I think what we're really missing in inflammatory bowel disease is prognostication. I think probably the lower hanging fruit is a biomarker that's more clinically accessible to patients. So point of care testing, for example, less stool-based assays because of the patient reluctance to complete that sort of testing, something that's just more generally uptakeable. I realize that's not a word. But I think the holy grail is moving towards prognostication in inflammatory bowel disease, which is really where we lack. So that profile study that I showed you, the early effective therapy in Crohn's disease, was really designed to be a biomarker study, looking at people who had a high level of the biomarker versus a low level of the biomarker, and it didn't pan out. But it's a good attempt, and I think we have to continue striving for that because right now we really don't have great prognosticative tools to determine who needs what therapy when. So I think that's what we should continue striving for.
Okay, thank you. So that's it for the questions for now. So I wanted to thank the audience for joining us today. We certainly covered a lot of information, and I hope that everyone found it useful. Dr. Click, really great presentation. So we really appreciate you doing this for us. And before I let everybody go, I wanted to encourage those of you that are attending the upcoming DDW meeting to attend 2 of the talks by another leading GI physician, Dr. Kayal from Mount Sinai. So she's going to be presenting on May 18th and May 19th. So I encourage you all to follow up with her there. But again, thank you, Dr. Click, and thank you to the audience.
Thanks, everybody.